The first case we are going to present is a 47 years old male, an heavy
Ma io
smoker with
partirei
a past history of
dall'alto.
alcohol abuse. So he underwent a CT scan last October, which showed an enlarged head of the pancreas with calcification and a focally dense lesion up to 30 millimeters in the uncinate process, which was confirmed by an MRI, which also showed a dilation of the biliary tree and of the main pancreatic duct up to 10 millimeters. In the images, we can clearly see the dilation of the main pancreatic duct and of the biliary tree, and on the right, the isodense lesion in the head of the pancreas. So we're going to perform an EUS in order to rule out cancer in the context of a chronic pancreatitis. And we're going to discuss about EUS signs of chronic pancreatitis and how to detect cancer in this not simple context. We can pass to the procedure.
Thomas Togliani is the operator.
As you have already heard, this is a 47 years old patient. He's a heavy drinker, heavy smoker. We have a clinical and radiological diagnosis of chronic pancreatitis. We are trying to see the pancreas, and we will try to assess the presence of a focal lesion in the uncinate process. Now you can see the descending aorta, the spine. We try to look at the here the arteries coming out from the aorta. Okay. The celiac trunk and the superior mesenteric artery coming out from the aorta here. Okay. I push down just a bit and I try to visualize the body of the pancreas. This is a left adrenal gland, the upper pole of the left kidney here. Okay, just a minute because he has got a hiatal hernia and I have to push under endoscopic vision. Can we increase sedation just a bit? He's coughing, so I'm sorry, but everything is moving. This is a pancreas, as you see, an inhomogeneous structure with slight calcifications and enlargement of the Wirsung duct and secondary ducts. Here, this is the body of the pancreas. The diagnosis of chronic pancreatitis seems correct. We see the neck and the Wirsung duct going down toward the head of the pancreas. It's enlarged with
Can we stop the aspiration for a minute?
yeah, okay. This is
So
the neck.
So
Yes.
Thomas, we can see a lot of calcification and we can see typical feature of chronic pancreatitis.
Yeah.
Is there any specific sign that you try to identify to make sure there is no cancer in this heavily phlogistic reaction at the level of the pancreas?
Well, till now I didn't see any focal
But you look
lesion.
specifically to something that is typical for cancer?
We are looking for cancer because CT scan saw a focal lesion in the uncinate, a 3 centimeter lesion, but we want to see all the gland. Here in the neck, body and tail, I don't see any suspect lesion, just calcification, enlargement of the ducts, and the inhomogeneous structure, but nothing else.
It looks like from the cross-sectional imaging, Thomas, it looked more like in the head or uncinate process. That's where the dilatation started, and you can see the pancreatic duct is dilated in the neck.
Yeah,
Um,
sure. It's slightly dilated. We can take a measure.
So, what is the best position to get to the uncinate process? You have to go down a lot. with the
Yeah, yeah,
scope.
yeah, sure, sure. Now we are, we switch to endoscopy and go down. No, non mi serve, grazie. We go in the bulb in the second portion to see the head and the neck and the uncinate. Sorry. This is a pylorus.
Tough guy, 47, quite young. Yeah.
It's a bit hard to pass the pylorus. Non insuffla. I've lost the insufflation of the probe. Non insuffla più.
Ale, non insuffla. È un'altra valvola.
I'm sorry, I've
No, we understand. We probably were talking about the fact that these patients being young and have a drink,
Grazie.
you may have some issues with the sedation. You need a lot of propofol to get the patients really sedated, quiet, in order to go properly down to the stomach, right? You're doing now.
And it's also complicated by the fact, Thomas, they have chronic pancreatitis, some amount of duodenal distortion. That combined with sedation, it can be quite challenging.
yeah. Okay.
But you're there.
We
You're
are
there.
in the bulb, as you see, the common bile duct, the head of the pancreas, the portal vein. The head too has the same appearance of the body, so inhomogeneous, small calcifications, and enlargement of the Wirsung duct. I go down to explore the wall, head.
What is the anatomical landmark to identify the uncinate process? What you use to identify that part of pancreas?
I go through the common bile duct and the Wirsung duct till the papilla, and starting from the papilla, I can see and find the uncinate. Now I'm in long position, and here maybe we can see something different in the gland because there is a lesion, maybe. If you,
Can you use the arrow to show the lesion to everybody?
yeah.
Okay, great.
Maybe this area is more hypoechoic than the other part of the pancreas.
Yeah.
What
The-
do you find different in this area? Can you tell us?
There aren't many calcifications like in the rest of the gland, and it's less echoic, quite roundish. It's obviously is different to assess focal lesions in a pattern of a chronic pancreatitis.
We have a room full of experts. I will make a question to the expert here in the room. Is there contrast medium can be helpful? Can elastography be helpful for that, or combination of both?
Yeah.
So there are a
Maybe we
couple of
can
experts.
start
So
with the
let's see what the expert
elastography.
says.
Maybe if you see this could be the focal lesion that CT scan saw, 3 centimeters, ok, puoi sfrizzare. We can use sonelasto and the contrast.
Combination of both.
I th- we are working with the EU M2 plus console. The scope we forgot to say it before. It's Olympus scope GF UCT 180. And now elastography maybe will tell us something more.
Yeah, beautiful colors. Can you please explain for non-expert like me? So there is a stiffness of the tissue. What are you looking for?
Yes,
Alessandro is only for the colors.
thank you, Claudio.
as you see, the lesion we are looking for is quite blue. Is a mixed colored blue and green. I expect that the chronic pancreatitis should have a mixed color, blue and green, and the focal lesion, if it's a cancer, would be more blue, which means harder.
Yeah,
So we've got Pietro here who's going to give us his opinion.
It's not so blue.
Potete aprire il microfono del professor Fusaroli?
Dov'è Pietro?
So are you able
Dici
to,
la domanda. Falla qua.
Thomas, are you able to do a strain ratio
Yeah,
on
okay.
the Olympus equipment?
Yeah.
And very provocative question for Claudio. Claudio, you hearing us? Claudio De Angelis? Where we are with the artificial intelligence and the US identification of focal lesions. So that's the next challenge, no?
Yeah, we definitely need some artificial intelligence because this is for sure the hardest situation. I wouldn't expect that much from contrast and elasto in this case because we have a lot of artifacts due to calcifications and the arrangement of the parenchyma. So it's true only for autoimmune pancreatitis that you can get some results with contrast, but classic chronic pancreatitis I would expect to be hypoenhanced and not get any significant advantage. The same for elasto. We see some very heterogeneous parenchyma, which is similar to chronic pancreatitis. But Thomas nicely showed that the first orientation always comes from a careful exploration with B mode.
So I think now the next question is, should we take tissue from the lesion or just follow up the patients for potential risk of cancer evolution? Who is in favor of taking biopsy in this situation? I would say that most of the experts are in favor of making biopsies. May I ask why you would like to make biopsies and which kind of biopsies? I didn't say.
Two questions. That's very good, Alessandro. So I think the reason I would consider doing a biopsy in this situation is what Thomas demonstrated, that there is an area of abnormality in the head/uncinate process which does not have as much calcification as the rest of the gland. So there is something abnormal that fits with his symptoms, which suggests that something has changed over the last few months. So that is the reason I would consider doing a biopsy. Which type of biopsy? I think, increasingly our cytopathology colleagues in the audience would like better tissue with a better preserved architecture. So personally, I would go for core biopsy rather than fine needle aspiration.
Do you think that do you think that contrast enhancer, the EOS, may be of any use here?
Uso il core
Can you hear me?
Yeah.
Yeah, I think Thomas, it might be worth
25.
doing because there is that area which is slightly different to the rest of the pancreas. You know, Pietro might disagree, but where contrast might help, if there is a specific area of hypoenhancement, we could target that part of the pancreas.
Yeah, we totally agree.
May I make a provocative question from non-expert of US? So I'm concerned that there is a lot of scar tissue into the pancreas. It's probably better to have a very thin FNA needle to get tissue over there in order to pass more smoothly through the chronic pancreatitis, or you think that FNB big needle is good as well as a normal situation?
Some people, some experts think that it could be better to have a very, very thin needle just to catch cells in the fibrous tissue. So someone can be in agreement with your observation, even if you are not an expert of EUS.
That's correct, Claudia. I think the ease of which a needle is inserted into a lesion or a mass lesion in the background of chronic pancreatitis depends on the type of needle you're using. Different needles have got different access. And we in Newcastle use the Medtronic core biopsy needle, which has very good penetration even in the hardest of lesions. There are some pancreatic cancer lesions which are extremely fibrotic and are difficult to get core biopsy or FNA needles into. But it's just, I think, trying for the pathologist to differentiate between chronic pancreatitis and malignancy in this patient is going to be the challenge.
I made the points because I'm also concerned about this co-position because it's a little bit far
Mauro,
down into the
si
third
possono prendere
position. This
foto?
may make some troubles to the advancement of the needle. And the other question to all the experts is, this is a very borderline situation where we need good information from the pathology. Is this a unique situation where ROSE may be helpful?
Again, I think there's
Possiamo
been
prendere
a
foto?
couple of meta-analysis recently highlighting the role of, highlighting the importance of ROSE. I think we used to have ROSE. We didn't show a lot of difference. There are other centers who have shown a difference. When you're taking a core biopsy, it's almost, it's very difficult for the pathologist to give an answer straight away unless they actually do a frozen section. In fact, we actually do have a pathologist in the audience who might be able to,
Sorry,
Sorry.
the discussion is very, very useful, very interesting, but we must go on with the case, so we will perform a contrast medium now with Sonoview injection. Let's have a look at the CHEUS, please.
Okay, we are ready for the contrast.
So can I ask which medium are you using, please? Which contrast medium?
Sonoview,
Sonoview.
1 vial.
Exactly where the
Mechanical index is 0.5, 0.20. The area remains hypovascular.
With this machine, you should put the focus at the very deep part of the screen in order to have a good contrast and to have a mechanical index of about 0.22.
Here is our lesion.
Yeah, it's nicely demonstrated, but it's what Pietro just said a few minutes back. It'll most likely hypo enhance, and that's what it's doing.
But I think there is a difference between the area with a lot of calcification that take contrast and the area where there are very few calcification and don't take any contrast.
Luca, what we expect from contrast exactly here? What we expect.
What I see, that there is an area, this pancreas is not homogeneous, because there is an area with a lot of calcification and a mass without calcification. This mass don't take any contrast, the other part take contrast. So for me, this is highly suspicious for cancer.
And will it help us target the lesion?
Armando.
I have a clinical question.
We
If
will.
you obtain a negative results, what are you going to do? Because if you decided that this patient has to be operated, all these examinations are useless. Because you have a patient, young patient, so if this is, you suspect that
Delago.
this is a cancer, also if you have a negative results, are you going to operate the patient or to follow the patient with which?
That's very good point. Claudio, you there?
Yes.
You are in charge of the patients. So did you hear the clinical point that has been
Yes.
raised by Dr. Gabrielli?
Can you hear me? Yes.
Yeah.
Okay.
So what was?
Yes, the clinical point is a very good clinical one, but what we want and what all the surgical community today wants, it is not to have so much DCP done for nothing. So we must try to have I know that even in the experience of Verona, that is the biggest surgical center for pancreas in Italy, they have at least 15% of their DCP done for a benign lesion and not a cancer in the head of the pancreas. So I think that we must try to have the best that we can. And before going to surgery, if we are not so confident about the possibility that there is a lesion, a cancerous lesion, a malignant lesion in the head of this pancreas, we should do any effort in order to have a diagnosis. And if the first biopsy will be negative, we will try to do another one in 1-2 months.
Okay. Good. So you are going to biopsy the lesion or not?
Yes.
Okay,
And
great.
we are using.
What are you preparing? Which kind of needle?
Yes, we are using a needle from Olympus, EZ Shot 3 Plus for biopsy, as you suggested just a minute ago.
So we want to see the needle now, eh?
Okay, please,
show
the
the needle.
camera. La camera, per favore, inquadri l'ago.
Thomas,
Yeah,
are there lymph nodes?
there's one lymph node with a benign aspect. I think it's reactive.
This is the needle. Now I think that we can move again to the EUS images. So you will see the needle in the lesion.
C'era la possibilità di fare spyglass ed eravamo in accordo che voi preferivate non avere spyglass.
It's biopsy. So people are asking about which size of needle you are going to use.
25.
Okay, 25.
The smaller.
Is there any different opinion on that? Yeah.
I think it's better to try to perform a fine needle biopsy, not fine needle aspiration in this case.
So, Thomas, is that a fine needle aspiration needle or a biopsy needle?
This is a fine needle aspiration.
Okay.
Pietro?
Also for FNB.
It's a thin needle, 25, because I'm in a very angulated position.
That was the point I raised before.
Yeah, in this case, I think you can try because of the difficult position, but maybe a larger core needle would be probably a better choice. Now the EZ3 19 gauge, always from Olympus, is a very flexible needle, which you could also consider using in this position.
But we must say, Pietro, that from a point of view of the needles, all the new EZ Shot 3 needles from Olympus, both the 25, the 22, and the 19 gauge needle, are certified also for FNB.
No,
Is
guarda,
that, Claudia, how
l'arteria
you
qua.
process the sample when you say they are a 25 FNA needle is is certified for biopsy too.
Yes, yes.
Okay. So I think while doing the
Yeah, we-
biopsy, we've got a pathologist in the audience from Croatia. What is your opinion on diagnosis of malignancy on the background of chronic pancreatitis?
Okay, Mike.
It is true that it's sometimes difficult to differentiate between chronic pancreatitis and cancer in small samples. So for this
Provometermin.
case, I would like to have aspiration
Provometermin
first
corta.
because a few cells will be enough. We expect ductal adenocarcinoma here if it is cancer. And of course, biopsy will be a plus. So probably the both.
Alessandro?
Sì.
Hello,
Ciao, Ilaria.
ciao. Hello, everybody. I think that the choice of the type and size of needle depend basically on the ability of cytologists in our center. So this is, I think, that is a major point when you choose which kind of needle do you have to use for a specific type of lesion. So for us, for example, I can't use a fine needle aspiration needle or 25 gauge needle because we have not cytology, and the pathologists ask us for a
Okay,
microhistologic
that's another
sample.
good point. So it's a local setting
Yeah.
that may require a specific type of biopsy. So it's not the endoscopist making
Yeah.
the choice, but it's the pathologist leading the way, no?
Yeah, on the other side, I think that in this case we need more tissue to have a diagnosis because the setting in which we puncture the lesion inside the chronic pancreatitis is very difficult to diagnose. So I think that in this case, a fine needle biopsy is more appropriate than fine needle aspiration.
Sorry, but
It's a very thin difference between fine needle biopsy and fine needle aspiration. So since I confess I'm not an expert, what is the difference between fine needle aspiration and fine needle biopsy?
Oh, basically the size of the needle and the technique that you use, because nowadays we
fanning
have
versus
the
non-fanning?
difference is if you have a core and you don't have a
Exactly.
core, both with 25 or with 22 or with
Exactly.
19 gauge needle.
So
If
it's
you
the
have a
result
core,
making the
It's the
difference.
result.
Okay.
This is the difference.